Most people believe that heart attacks happen because of exertion, that the heart fails when we lift something heavy, run, or get crushed under the weight of daily stress. I used to believe that too, even after completing my cardiology residency. That changed when I began reviewing the timing of the cases involving my older patients. A remarkably clear pattern emerged, one that I simply could not ignore. Between 6 a.m. and 10 a.m. lies the most dangerous window of the day, not at the gym, not during an argument or a stressful confrontation, but during the transition between sleep and wakefulness, in those first few minutes after the alarm clock rings. I had a patient named Remedios, a 73-year-old woman with well-controlled hypertension. She arrived at the emergency department at 7 a.m. on a Tuesday morning with a blood pressure reading of 195/108 and severe dizziness. Her medications were properly adjusted. Her diet was excellent. She had not engaged in any physical exertion. The only thing she did was get out of bed, as she did every day, abruptly, and head straight to the bathroom before her aging heart had enough time to prepare for the demands of the upright world. What I'm about to explain may permanently change the way you think about those first few minutes of the morning after the age of 60. I have spent years dedicating my work exclusively to the hearts of people over 60. Not younger hearts with cardiovascular risk factors, but aging hearts with their own unique physiology and characteristics, features that are rarely reflected accurately in general medical guidelines. I have reviewed thousands of electrocardiograms, interpreted thousands of ambulatory blood pressure monitoring records, and guided hundreds of older adults through some of the most difficult cardiovascular decisions of their lives. And there is one pattern I continue to see so frequently that it no longer surprises me, yet it still concerns me deeply. A heart over the age of 60 has a degree of morning vulnerability that a 40-year-old heart simply does not have to the same extent. Most physicians, however, do not have the 15 minutes necessary to explain this to you. To understand why the morning is the most critical time of day for a heart over 60, you first need to understand what happens to your cardiovascular system during sleep and in the precise moment of awakening. While you sleep, your body does something remarkably intelligent. It lowers your blood pressure by approximately 10 to 20% compared to daytime levels. Your heart rate slows down as well. The sympathetic nervous system, the system responsible for accelerating bodily functions, takes a break. Your heart literally uses those hours to recover from the demands of the day. Cardiologists refer to this nighttime decline as the nocturnal dipping pattern. When it functions properly, it becomes one of the ways an aging heart protects itself. But something happens between 6 a.m. and 9 a.m. that suddenly turns this balance upside down. Your body begins releasing cortisol, not the cortisol associated with chronic stress that everyone talks about, but the natural daily cortisol linked to your circadian rhythm. The adrenal glands release it at its highest levels shortly before waking in order to prepare your body for activity. This cortisol raises blood pressure, activates the renin-angiotensin system, and increases blood viscosity. In simpler terms, your blood becomes slightly thicker and more prone to clot formation during those early morning minutes. Imagine your cardiovascular system as the engine of a car that has been sitting idle in a cold garage all night. If you start the engine and immediately slam the accelerator to the floor without giving it time to warm up, the internal pressure rises sharply and the components are subjected to stress before they are ready. A young engine may have enough reserve capacity to tolerate that strain, but for an engine that has been running for 70 years, that aggressive start comes at a very different cost. This does not mean your heart is diseased. It does not mean your medications have failed. It simply means that the transition from sleep to wakefulness requires rapid cardiovascular adaptation, and a heart over 60 no longer performs that adaptation with the same speed or efficiency. The real enemy here is not high blood pressure itself. The real enemy is abrupt rising combined with the morning cortisol surge. It is a mistake that takes only 8 seconds, is repeated 365 days a year, and gradually accumulates silent damage inside an aging heart that may already have some degree of arterial stiffness. There is one finding from a study worth mentioning. 62% of acute cardiovascular events in adults over the age of 65 occur between 6 a.m. and 11 a.m. This is not a coincidence. It is physiology. Before we continue, I need to be very clear with you because we are discussing cardiology and details matter. If you experienced crushing chest pain this morning or at any time recently that did not disappear within a few minutes, stop watching this video right now and seek emergency medical care. If you suddenly become short of breath while at rest, Lose consciousness, feel as though you are about to lose consciousness, or experience palpitations accompanied by unexplained dizziness. These are not symptoms that should be researched online. They require an in-person medical evaluation. This video is intended for people whose heart conditions have already been diagnosed and are under control, who are taking cardiovascular medications, and who want to better understand how to protect their hearts during the most vulnerable period of the day. It is also for individuals over the age of 60 who wish to prevent problems that have not yet appeared, but whose physiology already places them within a higher risk category. If your situation resembles the first scenario, the video can wait, but urgent medical evaluation cannot. If your situation resembles the second or third scenario, keep watching. This content was designed specifically for you. Let me tell you about Roberto, a 71-year-old retired accountant who was diagnosed with hypertension 9 years ago and has paroxysmal atrial fibrillation that is well controlled with medication. Roberto was what he himself described as a compliant patient. He took his medications consistently, attended his follow-up appointments, and went for walks 3 times a week. Yet Roberto came to my clinic because, over the previous 6 months, he had experienced 3 episodes of severe morning dizziness, always at the same time and always in exactly the same way, during the first few minutes after getting out of bed. His previous cardiologist had adjusted his blood pressure medications twice and even added a second medication, but nothing seemed to break the pattern. When I asked him how he got up in the morning, he looked at me as if the question were unusual. "Your feet touch the floor?" he answered. "I'm not sure. Maybe 30 seconds. Less, perhaps." That single statement unlocked the entire mystery. In 30 seconds or less, Roberto's heart, which was already dealing with paroxysmal atrial fibrillation and blood pressure medications that included a renin-angiotensin system inhibitor, was being forced to transition from the calm state of sleep to the demands of standing and moving. Meanwhile, his blood pressure regulation system, what we call the baroreceptor reflex, the mechanism responsible for rapidly adjusting blood pressure when body position changes, was no longer responding with the same speed it would in a 40-year-old man. The result was exactly what had been happening to him. The combined effects of his medication, the natural morning cortisol surge, and his abrupt rise from bed produced a temporary drop in blood pressure of approximately 18 to 22 millimeters of mercury. His brain interpreted that drop as dizziness. The problem was not medication failure. The problem was a wake-up protocol designed for a 45-year-old heart being applied to a 71-year-old one. We made several simple adjustments without changing a single medication. 3 months later, Roberto returned to the clinic. He carried himself differently, steadier, more confident. He told me he had not experienced a single episode since the second week after making the changes. He replied, "Normally, the alarm goes off, I sit up, stand up, and head to the bathroom. I then asked him how much time passes between the alarm ringing and the moment. Then he added a sentence that has stayed with me ever since. Doctor, no one ever explained to me that getting out of bed the wrong way could affect the heart. I always thought it was only about the bones." Before we continue, I want to ask you a question. Has your cardiologist ever explained how someone with your cardiovascular history should get out of bed in the morning? Write your answer in the comments. I genuinely want to know how many of you have left a cardiology appointment without being told this fundamental piece of information. Now let's move into the practical side of things. There are 5 specific interventions that, when applied during the first few minutes of your morning, can significantly reduce the burden placed on a heart over the age of 60 at the very moment it needs protection the most. The first intervention is what I call the 3-minute wake-up protocol, and it may be the simplest change requiring the least effort while offering one of the greatest benefits I can recommend to older adults. I know what you may be thinking right now. Perhaps staying in bed for an extra 3 minutes after the alarm sounds feels more like an excuse not to get up than a medical recommendation. But hear me out for a moment. When you wake up, your parasympathetic nervous system, the system that kept everything calm during sleep, begins gradually handing control over to the sympathetic nervous system, the one responsible for preparing your body for activity and movement. For a heart over 60, this transition is not instantaneous. The baroreceptor reflex, the mechanism that regulates blood pressure within fractions of a second when your body changes position, can become up to 40% slower in older adults compared with individuals in their 40s. This means that if you stand up abruptly, your blood pressure requires more time to adapt. During that adjustment period, both your brain and your heart receive less blood flow than they need. Here is the protocol. When you wake up, before making any movement, take 3 slow, deep breaths while keeping your eyes closed. Then slowly sit on the edge of the bed with your feet hanging down and remain in that position for a full 90 seconds. Not 10 seconds, not 20 seconds, a full 90 seconds. During those 90 seconds, your blood pressure regulation system has enough time to begin doing its job. Your blood pressure is given the opportunity to adapt to a semi-upright position before you ask your body to handle the full demands of standing and moving. Only then should you stand up slowly, using support if necessary. This protocol is not intended solely for frail individuals or critically ill patients. It is designed for anyone over the age of 60 who has a heart that deserves those 90 transitional seconds we have rarely, if ever, given it. However, there is an important caveat. If you already suffer from severe orthostatic hypotension, or if your physician has provided specific instructions regarding how you should get out of bed, you should consult them first. This protocol is not a substitute for individualized medical guidance. The second intervention involves the timing of your morning blood pressure medication. And here I am going to say something that makes many physicians uncomfortable. I know what you may be thinking. I take my pill at the same time I've always taken it. But hear me out. Many blood pressure medications commonly prescribed to older adults, including angiotensin-converting enzyme, ACE, inhibitors, angiotensin receptor blockers, ARBs, and certain calcium channel blockers, have pharmacologic effects that may interact less than optimally with the cardiovascular dynamics of the early morning if they are taken immediately upon waking, before the body has completed its postural transition. This does not mean the medication is inappropriate. It does not mean the dosage is wrong. Rather, taking the medication during the peak of the morning cortisol surge, while your body is still transitioning from a lying to a standing position, may temporarily amplify blood pressure reductions during the first 15 minutes of the day. What cardiovascular chronobiology suggests is that there may be a window of approximately 20 to 30 minutes after postural stabilization, after you have stood up and your body has adjusted, during which taking the medication may be more physiologically efficient and less disruptive to morning blood pressure dynamics. The practical protocol is as follows. First, complete the 90 seconds sitting on the edge of the bed. Then stand up. Remain standing and stable for an additional 2 minutes. Only then should you take your morning blood pressure medication. I am not talking about changing the medication or adjusting the dose. I am talking about a timing difference of no more than 3 minutes. But the warning here is extremely important. Do not change the timing of any cardiovascular medication without first discussing it with your cardiologist. Some medications have specific timing requirements that take priority. Bring this topic to your next appointment and ask your physician whether it applies to your particular medication regimen. The third intervention involves sequential blood pressure measurements during the first hour of the morning. And I do not mean measuring your blood pressure only once after waking up. I know what you are thinking. I already check my blood pressure every morning like I was told. But pay close attention. A single measurement provides a snapshot of a constantly changing process. From a clinical perspective, what interests me is not just the number, it is the change. The difference between your blood pressure while lying down, while sitting on the edge of the bed after 90 seconds, and while standing after 3 minutes provides valuable cardiovascular information that most physicians never receive because most patients never collect it. The mechanism that makes this important is orthostatic hypertension, a condition that affects approximately 30% of treated hypertensive patients over the age of 65. In many cases, it goes completely unnoticed because routine office measurements fail to detect it. The protocol is simple. For 5 consecutive days, measure your blood pressure at 3 different times each morning. First, while lying down immediately after waking and before sitting up. Second, while sitting on the edge of the bed after 90 seconds. Third, while standing, 3 minutes after standing up, record all 3 readings. If the difference between the lying and standing measurements exceeds 20 millimeters of mercury in systolic blood pressure or 10 millimeters of mercury in diastolic blood pressure, bring this record to your cardiologist. This pattern is consistent with clinically significant orthostatic hypertension and may directly influence how your medication should be adjusted. 1. Important warning. If you experience severe dizziness or loss of balance during any standing measurement, sit down immediately. Do not perform this protocol on your own if you have a recent history of falls or fainting. The The fourth intervention focuses on nighttime and early morning hydration. And here, I am going to challenge a myth that is particularly common among older adults. I know what you may be thinking. I was told not to drink too many fluids before bed, so I wouldn't have to get up and use the bathroom at night. As a result, I often go many hours without drinking water before morning. Listen carefully. After the age of 60, the heart operates with a blood volume that is already less stable than it was in earlier decades of life. In addition, the kidneys become less efficient at concentrating urine overnight. This means that even if you drink relatively little water, you continue to lose fluids. Arriving at the morning in a state of mild relative dehydration, even if the dehydration is subtle, increases blood viscosity at precisely the same time that the morning cortisol surge has already begun to increase it as well. The combination of mild dehydration, peak morning cortisol levels, and abrupt rising from bed forms the trio I encounter most often in episodes of morning dizziness and in cerebrovascular events occurring during the first hours of the day among my older patients. The protocol is straightforward. Drink 150 milliliters of room temperature water, not more, during the 30 minutes before bedtime. Upon waking and before taking any medication, drink 200 milliliters of room temperature water while completing the postural transition phase and sitting on the edge of the bed. Not tea, not coffee, not juice. Just water. Coffee and tea have vascular effects that may place unnecessary demands on an aging cardiovascular system during the first 20 minutes of the day, particularly during the peak morning cortisol period. One final warning. If you have heart failure and your cardiologist has prescribed fluid restrictions, these amounts must be adjusted according to your individualized medical instructions. Continuation of the translation. Do not follow this hydration protocol if your physician has prescribed a daily fluid restriction. The fifth intervention is one you are unlikely to hear about anywhere else, because it requires a very precise understanding of how the cardiovascular circadian rhythm functions after the age of 60. Among many of my older patients who take beta blockers, and there are quite a few, there is a phenomenon I refer to as relative awakening bradycardia. When the effects of beta blockers remain active during the final hours of the night and the early hours of the morning, the resting heart rate may range between 52 and 58 beats per minute. By itself, this is not necessarily dangerous. The problem arises when a patient gets up abruptly and suddenly demands that the heart rapidly increase its rate in order to maintain the cardiac output required for standing and immediate movement. A heart slowed by beta blockers needs more time to respond, and that period of delayed adaptation, typically lasting between 45 and 90 seconds, is precisely when blood pressure drops are most likely to occur. The protocol I use with these patients is called gentle isometric activation while lying down. Before the patient sits up, and while still lying in bed, I ask them to perform 3 gentle contractions of the thigh muscles by pressing inward as though attempting to squeeze their knees together firmly, then relaxing. Each contraction is held for 10 seconds, followed by 5 seconds of rest before the next contraction. These muscle contractions activate the venous pump in the lower extremities, the mechanism responsible for returning blood from the legs back to the heart. In older adults, this is often one of the first components of postural regulation to decline. As a result, when the patient eventually sits on the edge of the bed, the heart already has a slightly greater volume of circulating blood available, making the transition less abrupt and considerably smoother. The outcomes I observed among monitored patients were noteworthy. In 68% of cases where this protocol was combined with the 90-second sitting protocol, episodes of morning dizziness either disappeared completely or decreased significantly within the first 3 weeks, without changing a single medication. However, there is an important warning. If you have a recent history of deep vein thrombosis, or if you have been instructed to maintain strict bed rest, consult your physician before performing any muscle activation exercises, no matter how simple they may seem. I want to pause here for a moment because there is something important I would like to tell you as a physician before I conclude. All 5 interventions I have described operate according to the same fundamental principle. Giving a heart over the age of 60 the time and conditions it needs to transition safely from sleep to wakefulness from a cardiovascular perspective. These are not 5 unrelated strategies. They are 5 different doorways leading to the same room.